we were very lucky together. Branch Council, same group.
Right, I remember that.
Good morning, everybody. So today we have Dr. Joseph Berger with us to speak to us. He's the professor of neurology and associate chief of multiple sclerosis at University of Pennsylvania. He graduated from Penn State, summa cum laude, and subsequently did his medical schooling at Jefferson here in Philadelphia. Then moved on to do internal medicine at Georgetown University, spent a year at Jerusalem, came back and did his neurology residency in University of Miami, where he practiced for almost 10 years. He did a lot of, being Miami, he had a lot of HIV patients, and sort of that was his beckoning. He did a lot of HIV neurology, and he was telling us that he got a $6 million grant to study the effects of HIV on the nervous system. Subsequently, he moved to Kentucky, as you can see from the slide, where he was the chairman of the department in University of Kentucky, again for another 10 to 20 years, and subsequently he's moved back here to University of Pennsylvania, so sort of a full circle. He's been the recipient of numerous grants and awards and written multiple papers, book chapters. He's one of the world's leading experts on HIV, medicine, neuroimmunology, multiple sclerosis. It's an honor and our pleasure to have him here to talk to us today. Please welcome.
Thank you. I think if we could just turn this bank of lights out, things would project better. All right. I hope you don't go to sleep during my talk. It's early in the morning. Well, thank you very much for having me here. It's great to be here. And it's nice to return to Philadelphia. I know I don't look that old, but it's been 42 years since I lived in Philadelphia. And I have, as I was telling some of the folks up front, I have a fondness for Kentucky, having lived there longer than I did anywhere else in my life. And this was actually taken close to where we used to live. We had a horse farm in Kentucky, but no horses because then you have to muck the stools, the stalls. And I don't know if you know what that means, but it's something you don't want to do. I'm going to give you a soup to nuts because Aparna said, you know what, let's hear about PML. You're a guru on PML. Let's talk about PML. I could talk about all sorts of things, but today we're going to talk about PML this morning. And I'm going to give you a soup to nuts from the history to the treatment and risk mitigation of PML. And the history actually starts in 1958 in this paper and brain by Astrom, Mancall, and Richardson. Elliot Mancall, some of you may know because he was a Philadelphian. He was at Jefferson at the end of his career, Harmon I think before that. But he was in Boston at the time this was written, and what they described were three individuals who had this unique illness, and it was unique on the basis of the histopathology. There were three unique characteristics of it that they had not seen with any other disease. It was called progressive multifocal leukoencephalopathy because it was progressive, it was multifocal, and it involved the white matter. But I'm going to tell you that it needn't be any of those things. We're going to talk about that, at least the consequence of the viral infection. They described it in three individuals that had underlying B-cell malignancies. Two with CLL, one with Hodgkin's disease. And we're going to revisit that because this B-cell story is an important story, and it was fatal in all three. And Richardson, who was the neuropathologist, said, you know, we don't know the cause of this condition. Most frequently, it's a complication of chronic lymphatic leukemia, which is what CLL was called at that time, or Hodgkin's. Whether there's some shared factor with sarcoid and TB remains unknown. Now, he mentioned sarcoid and TB because they really weren't the first ones to describe this. And like good investigators, they went back in the literature and they said, you know what, there are cases that are probably PML, but it wasn't put together, it wasn't crystallized as an entity. In fact, the very first two cases were described by a Nazi physician by the name of Hallerborn, whose name is being expunged from the neurologic literature is in large measure because of the efforts of Bob Daroff when he was the editor of Neurology. So that's 1958. A year later, Kavanaugh is looking at the inclusion body he sees in oligodendrocytes. And the triad, by the way, is enlarged oligodendroglial nuclei, bizarre astrocytes, and demyelination. That's the triad. The residents need to know it because it's going to show up on your boards. And he looks at he sees inclusion bodies. He says, you know what, this is probably a virus. And Gabrielle Zurain, who's working at the University of Wisconsin at the time, was doing electron microscopy, comparing what she sees with what's in the textbook, and she says, you know what, this looks like what we called then a polyomavirus. And or rather a papovavirus, not a polyomavirus. And she reports it at an American Society of Virology meeting and is met with a great deal of derision because nobody thinks that the virus that causes the warts on your hand can cause disease in your brain, okay? But she was right, and several years later, her colleague Billy Paget was able to passage it, but only in human fetal glial cells. So it had a tropism for glial tissue, human fetal glial tissue, and it took a number of passages, so it's not something that grows very readily. And it was called the JC virus because the man from whom they got it was named John Cunningham. That was his brain. And I find it very curious because whenever I write about it, I write JC virus, and the editors are writing back, no, you got to say John Cunningham virus. I say, isn't that a HIPAA violation? But they insist that they call it John Cunningham virus these days. There are 13 known human polyomaviruses. BK virus you may be familiar with because BK virus causes you to lose your kidneys after kidney transplant. It's a considerable concern. There's about a 50% homology in the DNA between BK virus and JC virus. So the virus is not very complex. I'm just going to get undressed here. It's not very undressed. It's a 40 nanometer non-enveloped double-stranded DNA icosahedral virus. We know its genetics. There are 3 regions of the genome. There's one region of the genome called the non-coding control region. So it doesn't code for any proteins, but it's very important for the tropism of the virus, whether it's going to grow in kidney tissue or other tissues or in brain tissue. Then you have a region of the genome that's called the early portion of the genome, and this codes for regulatory proteins. There are actually 5 regulatory proteins, some of which are truncated forms of others, that it codes for. And then you have the late region, which is transcribed late in the course of the virus, that codes for 3 structural proteins, VP1, 2, and 3, and an adenoprotein, which is also a regulatory protein. So that's it. There's a problem with JC virus, and the problem is you can't study it in animals. If I take this virus and I insert it into the brains of hamsters or New World monkeys, I end up getting astroglial and neuroectodermal tumors. I do not get PML. There is no animal model of PML. That's a huge problem. How are you going to study the disease if you don't have an animal model? It hemaggglutinates type O erythrocytes, and therefore the early studies, serologic studies, were predicated on having live virus in the laboratory and looking for the agglutination of type O erythrocytes. The virus binds to a combined 5-HT2A receptor and carbohydrate receptor, a sialic acid receptor. That's how it binds to the cell. And you could block this binding, we'll talk more about it, with drugs like mirtazapine. And that's why you'll see some of us give mirtazapine in people with PML. I don't think it does a whole hell of a lot, but it doesn't hurt. And I suspect that there are other binding mechanisms, but in any event, in the laboratory, you can block its binding in oligodendrocytes and glial tissues by blocking the 5-HT2A receptor. It then enters the cell through a clathrin-dependent endocytosis, which is pictured here, and you can block that as well with drugs like chlorpromazine. Then it ends up in the endoplasmic reticulum, then into the nuclei, gets replicated, and is released from the cell as thousands of particles when the cell dies from lysis. So this is the life cycle within the oligodendrocyte. In the human oligodendrocyte, the virus goes through its entire life cycle. In the astrocyte, it doesn't. And as a consequence, the astrocytes become big, bizarre, look malignant. In fact, many times the diagnosis is mistaken for a glioma because you see these cells that look like malignant cells, when in fact it's due to PML. So the early studies were done with this hemagglutination inhibition assay, and this is just a picture of what it looked like. And those early studies demonstrated that most of us are exposed to this virus. Most of us. In fact, if I were to pass a urine cup to every one of you in this room right now and look by polymerase chain reaction for this virus, I would probably find the virus in about a third. Now, that's not the very same virus we find in the brain because it has to undergo mutations. I'll tell you about it in a second. But this is an extremely prevalent virus. Probably 70–80% of us by the time we're adults have been infected by it. And in fact, there's one Japanese study, the only study I'm aware of, where they tried to figure out how you ended up getting infected because there's no acute infection recognized. When you were infected with JC virus, it's inapparent. And what they determined was that when they looked at the genome of the virus and compared it to that genome of the virus from the parents, that 50% of the time it came from the mother and 50% of the time it came from the father. So most of us are infected between the ages of 0 and 20. Here, you see how it goes up and then sort of plateaus. And it's likely that most of us are infected with our parents' viruses. This is like the herpes viruses, certainly herpes type 1, where most often it's your mother's virus that you've acquired. But it's likely that there are other sources of infection. Now, these are the seroprevalence rates. It varies from place to place, but and these are immunoassays that are done. But I think that a fair number is probably on the order of 70% of us are JC virus seropositive as adults. This comes from the Stratify study. You may be familiar with it. Certainly, if you practice MS neurology, you're familiar with it. Because Biogen, having a problem with natalizumab and PML, said, what can we do to lower that risk? The first thing that they went out and did, contrary to my advice, was to look for the virus. And that wasn't very helpful. So they looked for the virus in the blood and in the urine, couldn't find a correlation. But then they went back and they developed an antibody test. A fellow named Leonid Gorelick developed this laboratory test for them, and they found that by the age of 60, about 70% of people are infected. This, by the way, is an underestimate. I'll show you why in a second. Men, a little bit more commonly than women. Immunosuppressives had no effect. And so I was curious about this. We were part of the Stratify study when I was in Kentucky, and I had a funded study looking at interferons in MS patients and whether it had any antiviral effect. So when you're infected by a virus, there's an upregulation of alpha and beta interferons, which are antivirals. And I thought that if you were going to give somebody Avonex or Rebif or beta-seron or any of those, that it would lower the likelihood of you shedding virus in your urine because it's an antiviral. So I thought that the quantitation of the virus would be lower and the absolute number of people with the virus in their urine would be lower. And I had a fairly large group, 239 patients that I looked at and had well characterized on the basis of polymerase chain reaction of their urine. So I knew whether they had the virus in their urine or not, and then months, in some cases a year or two later, they get into the Stratify study because we became members of the Stratify study. So I know what their urine looked like. And then we did the Stratify study, and this got published in Annals. And what I showed was that of those that were shedding the virus in their urine, so here's 10 people, 10 of 27 antibody-negative people had the virus in their urine. So the study, the antibody study that we use right now, which is the focus laboratory study, the one you send off, the antibody index study, does not tell you whether or not the virus is in this person. Does not tell you that. And there are other studies, by the way, that have demonstrated this. So it's been recapitulated by others, not just me. What it does tell you, though, is something about the risk for PML. So it's a pretty good study, not a great study, but a pretty good study for Tysabri-related PML risk. This is what we think happens in individuals that are JC virus infected and ultimately go on to PML. Picture this though. I'm telling you that 70% of you are infected by this virus. Not one of you is going to develop PML, not one. I'm willing to bet $1 million on that. You're not going to develop PML. Say, well, that's weird. You know, think about that. Billions of people, how often do we see PML? Until HIV, I mean, it was rare. What is that telling us? That is telling us that there are enormous barriers to the development of PML. And I use the plural, barriers, because if it's just one barrier, it would be much more prevalent. So there got to be multiple barriers to the development that have to be lowered in order for you to develop the disease. We think the initial infection is probably an oral infection, probably with urine-contaminated substances. It replicates in tonsils. Monaco has demonstrated that at the NIH, that if you take tonsils and you look for the virus, you can find the virus in tonsils and parapharyngeal tissues, lymph tissues. Probably disseminates to sites of latency thereafter. The site of latency, and there was a publication in JAMA Neurology that I just wrote looking at autopsy patients, not with PML, but non-immunosuppressed patients, is the kidney. That's where this virus ends up. It ends up in the kidney. It can be found elsewhere, but it's largely in the kidney. And then it gets periodically re-expressed, and we think it gets periodically re-expressed in B cells. The virus that you find in the kidney is referred to as the archetype virus. That is the virus, that is not a virus that will grow readily in glial tissues, and it has to undergo a transformation in order to become a prototype or a neurotropic virus. It then finds its way into the central nervous system. There's got to be something wrong with your immune system, because even when it finds its way into your nervous system and establishes infection, you can control it. And we know that. We know that. I mean, I have patients with HIV whose immune system I've restored and whose disease is arrested. They do not clear the virus from their nervous system. Your PML patients with natalizumab who've survived do not clear the virus from their nervous system. It's still there. It's still there. It's just held in check. And how do we know it's still there? Because if you stick a needle in their back and you do ultra-sensitive quantitative PCR, you still find the virus. So we think that the virus enters this way, gets disseminated to the kidneys, gets released, and ultimately ends up in the brain. So there are a number of things, I'll just go through this, there are a number of things that have to occur in order for you to develop PML. And these are the hurdles to the development of PML. One is you got to be infected. If you're not infected, you're never going to develop PML. That's simple. We think that once you're infected, that the virus is there in everybody, sort of like HSV, CMV, EBV, etc. But we're not 100% certain. It's possible that some individuals are able to clear the virus. We don't know that. So once you're infected, that virus has to remain in your system. It then has to undergo a gene rearrangement because the likeliest form of virus you're infected by is the archetype virus, the one that's in New York. And then it has to get re-expressed. We think it gets re-expressed in peripheral blood mononuclear cells, enters the brain, establishes productive infection of the oligodendrocytes, and then you have to have some screwed up immune system to enable it to continue to replicate. So, go ahead.
Do you have any way of estimating how many of us have where the JC virus is already up in the oligos, even if we don't?
Yeah, so, well, we looked at that in the study that I just published. We didn't look precisely at the oligos, and the numbers are small. And all the studies that have looked at this, the numbers are small. We will find it in the brain. We will be able to amplify it using polymerase chain reaction. However, you don't find it replicating. So it's there, but it's not replicating. And we didn't genotype the virus, but there's one study I'm familiar with which they did, and in that study they did find the prototype virus in the brain, but not replicating. So it's probably small numbers. We're probably talking about 5%, maybe. But more studies need to be done. Now, what I've told you is a theory. This is, this is our best evidence. And I like quoting H.L. Mencken, among others. There's always a well-known solution to every human problem, neat, plausible, and wrong. So that if you invite me here a year from now and I talk about PML and I tell you something entirely different, it's because we just got smarter, okay? So this is the working theory. We think it's a good one. It's probably right, but, take it with a grain of salt. It is a recrudescence of a latent infection. This is truly an opportunistic infection. Okay, opportunistic infection. What are opportunistic infections? So an opportunistic infection is one, at birth, you're pristine. And then during the course of your lifetime, you acquire these infections. You get toxo, you get TB, you get CMV, you get herpes simplex, you get EBV, you get that you do not clear. They're in you, they're there. And every now and then, they recrudesce largely because of an impaired immune system. And that's an opportunistic infection. I liken it, I used to love doing this. I did this in Miami where everybody had swimming pools. If you have a swimming pool, you have two things to keep the pool clean. You have a filter, and you have chlorine that you have to put in every month. You don't put the chlorine in, or every week. If you don't put the chlorine in, what happens to the pool? Or if the filter fails, what happens to the pool? It turns green, right? It turns green. There's all sorts of schmutz growing in your pool. Organisms that are growing in your pool. Well, your human body's just like that. There's always a low level of schmutz in your body. Your immune system keeps that schmutz down so you don't turn green. Something like that. Anyhow, what's the evidence that this is a recrudescence of a latent infection? Well, one is we see IgG, not IgM, generally when people have PML. It's a very rare disease in children, though I've just seen it and described it in children. If you obtain blood in advance of PML, on occasion you can find the virus in the blood months before the infection. There are 6 cases that I'm aware of. There may be more. One of them was one of my patients with Wiskott-Aldrich syndrome, who had tissue obtained years before. He had tissue obtained 4 years before, a lymph node 4 years before he developed PML. And the virus found in the lymph node was identical to the one that was found in his brain. But most important is the data that's come out of the natalizumab-associated PML. And that is that almost everybody has antibodies 6 months before they develop this disease. Almost everybody. This is the change that has to occur. So this is what the non-coding control region looks like. And virtually everybody, not all, but virtually everybody that develops PML has what's called the 98 base pair tandem repeat, in that, this is that red region, in their non-coding control region. And that can occur not as a consequence of virus DNA contributed by other viruses or something like that, but simply by the consequence of deletions and duplications and the typical things that happen to the genes in your body. In actively replicating organisms. So that was demonstrated many years ago by Dick Frisk at Penn State. There may be other genetic mutations that increase the risk, and this comes from a study by Berger, in which they found the people that had natalizumab-associated PML very often had this point mutation in one of the structural proteins called VP1, so this serine 269 codon point mutation. The caveat is that you can find JCV in normal brains. In these studies, I told you 10%, it's 18 to 56% from these studies. I think that's probably a little high. You can find the neurotropic virus, and you do not find active replication of the virus in these brains. So what are the barriers? The barriers are virological, they're immunological, and they're probably host factors that are ill understood. And they interact with one another. Interestingly, there was a paper presented at the last ECTRIMS, and I've not seen it published. So, people say, do you go to the posters at these meetings? And I say, well, just for the wine. And I'll tell you, 90% of the crap that's presented at meetings, I don't care what meeting, never makes it into print. So until I see it in print, I'm not so sure that it's real. But they found 3 genes that seemed to increase the risk, and they were unable to tell you what those genes did. But there are likely to be underlying genetic factors that increase one's risk. I like defining the PML in terms of time into epochs. So we had the pre-AIDS era, where this disease was a back-of-the-textbook disease. What do I mean by that? When David and George and I went to medical school, I don't think they talked about PML, or if they did, it was like one sentence. You know, it was one sentence. Who the hell saw PML? Nobody saw PML. And then the AIDS epidemic, it was explosive. It was explosive. So 1 in 10 to 1 in 20 individuals that have HIV in the absence of treatment go on to develop PML. By the time they die, they develop PML. That's how I got such a big experience with it. And I'll tell you more about that in a second. And then with art, that declined very considerably, so now it's about 1 in 100. And now we have the monoclonal era that started in 2005 with the recognition that Tysabri can be associated with PML and probably other drugs, but not to the same extent as natalizumab. So this comes from Ben Brooks and Duard Walker, who, while at the University of Wisconsin, which at that time was the epicenter of PML research, put together this review. And they were able to identify 230 cases, scouring the world's literature, published and unpublished cases. From 1958 to 1984, 230 cases all told, only 69 pathologically confirmed, and of those, only 40 virologically confirmed. I show you this only to show you a couple things. One is, at that time, nearly 2/3 of all people who had PML had a lymphoproliferative disorder. Recall that the very first description were in people that had CLL and Hodgkin's disease. That's what this is. These are B-cell malignancies, not exclusively, but almost exclusively. 6% had myeloproliferative disorders, 2% had carcinoma, 16% had immune deficiency states. Recall, this was published in 1984. AIDS was described in 1981. At this time, there were only 5 cases of PML with HIV in the world's literature. One was my patient, one was Carolyn Britton's, and another came out of New York with David Simpson's group. So it constituted a small sliver of these immune deficiency cases. 7% had diseases like sarcoid and TB, granulomatous and inflammatory diseases, and in 5% they couldn't find an underlying cause. Now, remember this is 1984. You know, we didn't have the understanding of the immune system we have now, and even now, our understanding of the immune system is still in its infancy as far as I'm concerned. But we didn't have things like CD4s and CD8s. We didn't understand idiopathic CD4 lymphopenia or CD8 lymphopenia. So that number right now is probably less than 1%, where you can't find something wrong, okay? And the patient comes in with PML.
Dr. Berger, at that time you have the CT scan. Did any CT scan of the brain show anything? Or?
Yeah, I'm going to get to that. Don't
Right.
sit tight. Of course it did. So, 230 cases, 1958, 1984, the entire world. This is my experience in South Florida, published in 1998, which was from 1981 to 1994. I collected all the PML cases we saw down in South Florida. 156 PML cases. One had Wiskott-Aldrich, one had Hodgkin's, everybody else had HIV. Now, it was probably a bit skewed because I was an HIV doc. But think about this. That's how explosive the damn thing was. I mean, they're looking all over the world. I'm sitting in Miami, and this is what we have. So HIV really increases your risk of PML, and this is just a picture, Venn diagram showing it. So here's the HIV cases here. This is the number of people with PML. It was 10 times the number with other abnormal cell-mediated immunity. And this is the immunologically healthy population, and you could not make that dot small enough in PowerPoint. It just, you couldn't do it. It turns out that there are certain diseases that predispose you to PML, regardless of the treatment. So rheumatoid arthritis, Hodgkin's lymphoma, CLL, SLE. These are diseases that increase your risk of developing the disease sarcoid. despite the fact that you may or may not have been treated with immunosuppressive condition. Why do we see so much PML with HIV? And I think this is informative. Why do we see this? And I wrote a paper before the natalizumab story, and there was one thing that I left out, and I regret having left it out. I just wasn't smart enough. But one of the reasons is this difference in degree and duration of cellular immunosuppression. I mean, you're really knocked out with HIV, and we know that there is an impaired neural immunosurveillance that occurs in the setting of HIV, and there's a decrease in JC virus-specific cytotoxic T lymphocytes. Another, and this was the one that I was unaware of, you know, with HIV, there's an enormous B-cell activation. I mean, all these people have hypergammaglobulinemia. Why the hell do they have hypergammaglobulinemia? Because their B-cells are activated. So, well, that's weird. It didn't even occur to me when I was writing this paper that that had anything to do with this. It was only until natalizumab and the role of the B-cell with natalizumab, and we'll talk about that, that it became apparent that that is likely to be contributory because the virus can sit in B-cells, as Sid Huff and Gene Major showed, and it can replicate in B-cells. And it's replicating in a milieu that is uniquely engineered to change the genome of the virus. There's a facilitation of JC virus lymphocyte entry into the CNS. There's a disruption of the blood-brain barrier with HIV. We were talking about this last night at dinner, how quickly HIV gets into the brain, disruption of the blood-brain barrier, upregulation of adhesion molecules. And we know that the virus, the JC virus, can be transactivated by the HIV TAT protein and by various cytokines that are elaborated in the brain as a consequence of HIV infection. So we think that's what happened. Now, everything changed in 2005 when there were 3 case reports, 2 with MS, 1 with Crohn's disease, of people that developed PML in the setting of natalizumab, and then Igor Koralnik and I wrote the editorial that accompanied it. And these were 3 patients, 2 of whom had been in the Sentinel study, which was a combination of Avonex and Tysabri. One of them was a patient with Crohn's disease, so it was 2 of 1,171 on Tysabri and Avonex. It was 1 of 248 being treated for Crohn's disease. And this is very interesting. Now think about this for a second. I've been practicing medicine a long time, and some of you may know Bill Sharmata, now deceased. But Bill was the MS maven down at the University of Miami. And Bill, in the time when we didn't have interferons or anything else, when we had a bad MS patient, we treated them with Cytoxin, we treated them with Imuran. We made people very, very sick. I remember having people with all sorts of infections in the hospital because of the junk we were giving them. Nobody had PML. No case of PML had been reported with MS. No case of PML had been reported with inflammatory bowel disease, despite the fact that we did the same thing. So here we're severely immunosuppressing people. We didn't see PML. So these are not diseases that predispose you to the development of PML. And the thought was initially, well, maybe it's the beta interferon with the Tysabri. I told Biogen that wasn't the case. I was right. And the estimated incidence at that time was 1 in 1,000 after 17 months of therapy, 18 months of therapy. In fact, I'll show you the latest data on that. This comes from Sarah Guins, who looked at cases where patients developed PML after the discontinuation of natalizumab. And what we see is that most of the cases occur within the first 2 months after the discontinuation, but it still occurs out to 6 months. Now, they claim that it doesn't occur after 6 months. I will tell you that is clearly not the case. And we have this risk mitigation strategy, I'm going to get into that in a little while, where, well, think about this. So there are label changes that occur. In November 2009, the duration of therapy with natalizumab greater than 2 years had put on the label because more than 2 years of therapy is associated with an increased risk. Prior use of immunosuppressives put on the label in July 2010, and JC virus antibody assay put on the label in January 2012. You would think that this curve would flatten. You shouldn't see any more natalizumab-associated PML. That's not the case. The curve has not flattened. It may have inflected a bit, but not much. And that, I think, is surprising, that we have these risk mitigation factors, yet we still see natalizumab-associated PML, which means either the doctors aren't adhering to the regulations, to the risk mitigation strategies, or they're not great. And my sense is that both are correct. So why does natalizumab, unlike HIV, how does natalizumab increase your risk? And by the way, the risk of PML with natalizumab, in the right context, is identical, in fact exceeds the risk with HIV, the risk of PML with HIV. So it is a not inconsiderable risk. So natalizumab, as you're aware, is an alpha-4 beta-1 integrin inhibitor. It's alpha-4 beta-1 and alpha-4 beta-7. Alpha-4 beta-7 is what keeps the cells from getting into the gut, has no effect on the central nervous system, and is not contributory to the onset of PML. There are drugs that are simply alpha-4 beta-7 integrin inhibitors like vedolizumab, which is Entyvio, I think. It does not cause PML, despite what you hear on television. It does not cause PML. So it binds and it keeps inflammatory cells from entering the brain. Keeps these immune. So you're not immunosurveilling the brain. And you have these JC virus-specific cytotoxic T lymphocytes, which correlate best with the presence of PML and the survival with PML. And you've kept them from entering the brain. Well, that can't be good. And so it does that. It prevents about 80% of these cells from getting in, and it lasts quite a long while. So Olaf Stuve demonstrated that CSF lymphocytes are altered for up to 6 months after you've given that one course of natalizumab. You look at the lymphocyte subsets in the spinal fluid, and it looks like that of an AIDS patient. But so this is a demonstration of that. This is the T cells being prevented from getting in and surveilling the infected oligodendrocytes, but it does something else as well. So you have these premature B cells, they rest in your bone marrow and spleen. And those premature B cells can be infected by JC virus, and when you give natalizumab, it blocks the alpha-4 beta-1. That alpha-4 beta-1 is necessary for those cells to remain in place in the bone marrow, and it forces them out. So you get this increase in premature B cells carrying the virus, going through their maturation cycle. So it goes from a premature B cell out to a plasma cell, or a more mature B cell. In the process, we know that these transcriptional factors that are necessary for the maturation of the B cell, and this has been shown at Temple by Kamel Khalili and his laboratory, that as that happens, these transcriptional factors can upregulate JC virus replication. And there have been papers like one by Elliot Froman that have demonstrated that after natalizumab, you can find the virus not only free, but in the B cells. And he also demonstrated that you can find it in individuals where you can't find any antibody circulating after the administration of natalizumab. Now, there are probably other factors as well, ill understood, but there appears to be, after the administration of natalizumab, this upregulation of certain transcriptional factors like NF1X and SPI-B that are necessary for binding of the virus to the cell. So there are probably a number of factors, but most importantly, the B cell release and the impaired immunosurveillance. And this is the Froman paper that was published in JAMA Neurology in 2014, where he demonstrated the mobilization of these premature B cells called CD34 cells, and that these CD34 cells can contain JC virus. So in this particular instance, he found that, I think, 31% of them had the virus in their CD34 cells. Now, PML has been associated with other drugs. It's not just natalizumab. So here's just a list of, and this is probably a partial list. Some of them include drugs that we as neurologists use, dimethyl fumarate and fingolimod. And as you'll hear at Ectrum's, teriflunomide. But the risk is very, very different. So I thought about this. This was a former resident of mine in Miami, Faria Sohira. She's now on the faculty at the University of Texas in Houston, or at Baylor. And I said, you know what, there are two drugs that really very different than the others. One is natalizumab, the other is eculizumab, which is now off the market. It's an anti-LFA1A. It was used, it was taken off the market by Merck because of the risk of PML. And it does many of the same things natalizumab does. They almost work identically. And Merck was considering, this is Merck Germany, not Merck US, were considering using it for MS, starting a study in MS. Now, how do we distinguish these drugs? Well, to begin with, natalizumab and eculizumab, which I classed as class 1 drugs, are associated with, they're treating diseases for which you have no underlying risk of PML. No PML has been reported with psoriasis, MS, or Crohn's. Whereas these other drugs that are associated with an increased risk, where do you see the PML? You see it with lymphoproliferative disorders that are being treated, rheumatoid arthritis, lupus, HIV patients. Well, you already have a risk in those diseases, okay? The second is there's a latency. So if I give you natalizumab today, you're not going to develop PML tomorrow. If I give you natalizumab today, you're not going to develop it in a month, 2 months, 3 months, 6 months. It takes time to develop. Most people develop it after 18 months, okay? So it doesn't happen like that. And that's true of eculizumab as well, where it took 3 years to develop the disease. However, with rituximab, if I give you rituximab today and I'm treating you for lymphoma, you could develop the PML in 2 weeks. There's no way you develop PML in 2 weeks. It's just, that damn thing was in your brain. I just let the horses out of the barn and it went rampant, that's all. So it's very, very different. The third is the frequency. I mean, we're talking enormous frequency. We're talking, in the calculations that Bob Fox and I did and published, and then a German statistician and I did and published, the risk can be as high as 1 in 50 with natalizumab. If you're JC virus positive, high titer. If you have been on the drug for 2 years and you've had prior immunosuppressive therapy, it's closer to 1 in 50 than 1 in 80, which is what Biogen's published. On the other hand, with rituximab, you're talking about 1 in 30,000. And that's even individuals that have had a risk for the disease. That is, some underlying disease that puts you at risk. So you're talking orders of magnitude different. And this comes from a paper published in MSARD, in which I just looked at PML therapy with disease, PML risk with disease-modifying therapies. Natalizumab was up at the top, alemtuzumab, rituximab, mitoxantrone, teriflunomide, daclizumab, down at the bottom, low potential or no potential. And then dimethyl, I may have to redo this with the recent teriflunomide case, but that was a patient that received natalizumab before. Dimethyl fumarate and fingolimod, where the risks are significantly less, but there is a latency. That is, you do not develop PML immediately. So it probably does something in the pathogenesis of PML. So these are some of the estimated risks. I'm going to come back to that in a second. Let's talk about the clinical manifestations. This comes from the HIV series that I told you about. Symptoms, the most common in my series was weakness, cognitive impairment, speech abnormalities, headache, gait impairment. Most common signs, hemiparesis, gait disturbance, cognitive impairment, dysarthria, dysphagia, hemisensory loss. Now, in some series, you'll see visual defects, that's at the top. And in others, like the natalizumab series here, you'll see cognitive and behavioral problems as the most common presenting manifestation. I want to draw your attention to this, and that is no clinical symptoms. So that number is now 8%. Because we screen people that are on natalizumab, we do MRIs, and very often we will see evidence of the disease on MRI before the patient says anything. And in fact, the first case that was reported, one of the first cases by Annette Langer-Gould, and I'll show you in a second, was somebody in whom they had a screening MRI. They thought it was MS. The lesion was MS. They treated him with steroids. But the patient had no symptoms at the time. So this was one of my Kentucky patients.
How long do you see me? Can you describe me? Can you point to me? Point to me. How many fingers am I holding up? Where's my hand? Can you point to my hand? Right there? How about now? Can you point to my hand now?
Okay, so the residents, tell me, what does this man have? He's got a syndrome. Anton syndrome, right, and this was his MRI. So he had a denial of illness. He thought he could see me, and he was giving me answers. He was an HIV patient with PML. Neuroimaging is extremely helpful. You ask about CT scans. The CT scans are not as sensitive as the MRIs. You'll see hypodense lesions. On occasion, you'll see contrast enhancement. There's a lot of BS in textbooks. And among the BS that you'll find in textbooks is there's no contrast enhancement with PML. That's not true. So in my series of 154 patients, 10% of them had contrast enhancement on CT scan, so with iodine, and 15% had contrast enhancement with gadolinium.
But then you introduce the new concept, we have enhanced, and we see this inflammatory PML.
Yeah, so this was in an era before we had antiretroviral therapy, so I guess it's possible, but all I'm telling you is you can see enhancement.
I'm interested, before the MRI now it's so sensitive, I'm just curious, before the MRI, how do you look at CT? I like to look at the first image.
I'll show you, I'll show you.
Scan,
So on MRI, you'll see increased signal on T2 weighted image and flare. It's typically hypointense on T1 weighted image, which is helpful in the HIV infected person because the HIV infected person very often has white matter abnormalities, but it should not be hypointense on T1 weighted image. You generally don't see that. There's usually no mass effect. On rare occasion with iris, you can see it. The areas of the brain generally involved are parietal, occipital, and frontal, but you can see it virtually anywhere. Cerebellum, brainstem, basal ganglia. Remember, there's a lot of white matter that courses through the basal ganglia, temporal lobes. You can have this rare faint gadolinium enhancement, as I told you, and occasionally, and that's very common with natalizumab, 30 to 40%. And it occasionally follows tracks into the brainstem and spinal cord. The other thing that you often see are punctate lesions. There's a lot of these punctate lesions, and these punctate lesions, if you watch them, they grow and grow and grow, and then they coalesce into a bigger lesion. And you know what that is? That's the oligodendrocyte bursting, spreading the virus, in different areas, and then other oligodendrocytes being involved and just growing in that fashion. So these are people that came to autopsy. Judy Post and George Hensley and I put these cases together. This is the CT scan of this person. And here you see the lesion on CT scan. And here you see it on MRI. But I doubt you'd have picked up this lesion or this one down here. I mean, you might have, but. This is T2 and T1 weighted imaging, same level, multiple lesions, subcortical. This is a very interesting patient of mine. This is an individual who was a young man. He was 14 years old when I saw him, and he was from Pennsylvania, actually. He had a disease called congenital biliary atresia. And he had 3 liver transplants before one took. And it was done by a fellow named Thomas Starzl, who was the world's authority on liver transplants at the University of Pittsburgh. And he developed CMV with all the transfusions he got, but what they didn't realize is he was HIV infected at the same time. This is very early on before we tested for HIV. And he did well until age 6 when he had bad psoriasis, and an astute pediatrician said, you know what, bad psoriasis in a kid, that could be HIV, given your background. We had HIV testing at that time. And he was proven to be HIV infected, and he came to see me with an aphasia. And this is his MRI, and obviously he died. This is his autopsy. So the reason I show you this is the remarkable correlation clinically and pathologically. So here you see this moth-eaten appearance subcortically, here, 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 and there you see it right there. This was a patient who came to see me with a diagnosis of MS. This one on the left, the cerebellum. So the story is this. He was a man in his 20s. He lived in Fort Lauderdale. He developed ataxia. he went to see a neurologist. The neurologist put him into Broward General Hospital. At that time, we used a drug called ACTH. We infuse it intravenously. We had no other drugs. I mean, he had steroids. And he was getting ACTH. Now, it's very unusual for a patient to present with isolated ataxia and an isolated lesion in the cerebellum. That's a little weird for MS, but that's what they thought he had. Because when they did his spinal tap, he had elevated IgG and oligoclonal bands. By the way, elevated IgG and oligoclonal bands are very common in HIV infection. So he's getting this ACTH every day. The neurologist goes in to see him. The neurologist says, well, this is weird. You know, no women are coming to see him. One day, like the 4th day of hospitalization, there's a man in bed with him. He said, shit, maybe he's got HIV. And he does an AIDS test. He still thinks he has MS. And it's positive. So at that time, nobody wanted to treat AIDS patients. You know, I'd always take them down to Jackson Memorial Hospital. I'd say, all right, go ahead, send them. We'll take care of them. So they sent him down to me, and I said, this is an MS. I think this is PML. And we biopsied him, and he turned out to have PML. And here's a person with a third nerve palsy, and that turned out to be a PML lesion. On FLAIR, here's a lesion in the brainstem. This is PML, and it's hypointense. You don't see much contrast enhancement in that one. There's another interesting finding, and that is you can find on GRE or on susceptibility-weighted imaging this black rim, you see that, around the PML lesion? And we think that's macrophages that have taken up some of the oligo products, and there's iron there. But it's not entirely clear what that is, but it's a clue. And here's an example, I think Justin MacArthur gave me this slide, of how quickly PML can advance. So here it is in June of 2011, here it is in July of 2011, roughly 3 weeks later, much larger lesion.
So do you have any pathology of any of those dark zones?
Yeah, no, I mean, I don't think anybody's done that yet, but, so it's all speculative. Here are the punctate lesions I was telling you about that will coalesce, and it may be an early sign. We see it here in the brainstem. And there are ways to tell the difference between MS and PML, which is an issue when you are treating patients with MS with natalizumab or fingolimod. Obviously, there are certain clinical features that are clearly not PML, optic neuritis, transverse myelitis. Not to say that PML doesn't affect the spinal cord. It can. There are at least 4 or 5 cases in the literature. But it doesn't cause transverse myelitis. In fact, you do not see spinal cord clinical manifestations. They're overwhelmed by what happens in the brain. I do think I have one patient who presented with a myelopathy, but I couldn't get an autopsy on him. There are things like periventricular distribution, Dawson's fingers, and the nature of the gadolinium enhancement that can be helpful. And Nancy Ricker has put together a list of things that can be helpful in terms of distinguishing PML from MS. In the interest of time, I won't go through that. It should be in the PDF that I made available. These are the 3 pathologic findings: demyelination, bizarre astrocytes, enlarged oligodendroglial nuclei. This is that moth-eaten appearance subcortically. Here is an H&E Luxoff fast blue stain. This should all be blue. Pink cortex, blue white matter. Where's the white matter? It's all gone. And I want you to look at this. Look, there, 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 there. What did I tell you? There are these little holes that we see where the oligodendrocytes have been disrupted, and then they coalesce. You see puffballs of demyelination. They occur in a perivenular distribution. The axons are typically preserved. Occasionally they're not. They're bizarre astrocytes, and they're enlarged oligodendroglial nuclei that look like fried eggs. This may show up on your boards as well. You can confirm the diagnosis with electron microscopy, or better with immunohistochemistry, or by PCR. It's said that it doesn't cause necrosis. That's nonsense. Here's the case, provided you live long enough, right? If you don't live long enough. But you can get shrinkage of the brain in the affected area. And it's not the only disease that JC virus causes. So there are other brain diseases. This comes from a paper by Igor Koralnik. Granular cell neuronopathy, JC virus encephalopathy, and there's even a JC virus meningitis. These are very rare, always in severely immunosuppressed individuals. Granular cell neuropathy has been reported with natalizumab. So we should see it with other things like Jelani, I suspect. This is a case of granular cell neuropathy where you see the cerebellar atrophy, and the involvement, the JC virus, is in the granular cells of the cerebellum. This is one of my patients with this disorder at a time that we didn't recognize it. Actually, we recognized it, but I didn't let Sue Margello put it in the paper, or emphasize it in the paper. What happened is David Simpson, Sue Margello, David Simpson and Sue Margello, who are at Mount Sinai, and I put together 8 cases of this with HIV. We didn't know what it was. We just said it was cerebellar degeneration with HIV. That's how the paper was written. In one of the patients, mine, we had tissue on, Sue found JC virus. This is in the era before PCR, so it wasn't that easy to find JC virus. You couldn't grow it. I mean, you couldn't easily grow it. You'd have to send it to Duarte Walker or something. And we put in there that we found the JC virus, but we didn't realize that it was due to JC virus. Obviously, this is a Miami case, not a Kentucky case. That's if any of your movement disorders people, that's Carlos Singer when he was a fellow. Severely ataxic. She was a Puerto Rican sex worker. I had this other case at the same time. He was a Cornell radiologist who was married, had 3 kids. Very successful, very well known. And he had this proclivity to go on these cruises for gay men. I mean, his wife had no idea, and he came in with this disorder. Here's a case of JC virus encephalitis. And how do you establish the diagnosis? So this is from a paper that was published in Neurology in 2013. The gold standard, of course, is biopsy, find the triad, and demonstrate the virus there. But in the absence of that, clinical picture, MRI compatible, spinal fluid showing JC virus, okay? And no other disease would be helpful. This is that case I was telling you about. This is a Netlinger-Gould's case. So here's, this guy's in a study. He's getting Avonex and Tysabri. He's doing fine. They repeat the MRI because that's part of the study. And they see this lesion in his frontal lobe. Now that doesn't look like MS. This was radiographically isolated PML. And he gets treated. He ultimately became symptomatic and ended up moving to Dallas. Elliot took care of him, Elliot Froman, and he died after about 4 or 5 years. The JC virus DNA is not sufficient to make the diagnosis. So I'll frequently be asked, oh, you know what, we have this patient. You know what happens? Residents, when they order tests, they order everything. And one of the things you end up getting is, you know, JC virus PCR, not because you think the patient has PML, but because, well, it's on the list, I might as well click the damn thing, right? And then it comes back and you have 5 copies of JC virus per ml, and you go, well, wait a minute, there's no clinical manifestations, there's no MR manifestations. What the hell's that all about? So it turns out that you're not pristine. I told you that already. And there was a very nice study done by Iacobius with Gene Major, in which they took spinal fluid from patients at the Karolinska who had MS, where the spinal fluid was banked long before natalizumab was available, and they looked for JC virus in this banked spinal fluid. And guess what? 1 to 2% of the people had the virus demonstrable in their spinal fluid. And that shouldn't be surprising. Many years ago, in the process of looking at HIV patients, I used to tap patients as part of a study, and I had 500 patients enrolled, of whom 186 I tapped at an annual basis for 5 years, and their loved ones who were HIV negative. And one of the things we found is you could find, and this is before PCR, so we had a culture of the virus. We found enterovirus, we found adenovirus, on occasion we found the herpes virus, and otherwise normal people. So you think that, you know, that there shouldn't be any infection there, but occasionally things percolate through. This is survival. It's crappy in the absence of restoring the immune system. Most people are dead within months. With the availability of heart, the survivals improve very considerably. So in people that are PML, HIV-associated disease, the survival is at least 50%. Mortality is 50%, when before it was well over 90%. And there are a number of factors that indicate good or poor prognosis. This is with natalizumab, it's a little different with HIV. If you're old, if you have more disability, if you have a higher JC viral load and you have more extensive disease on your MRI, you don't do as well. And I think that those things are probably self-evident. One of the things that I had indicated before is the presence of this JC virus specific cytotoxic T lymphocyte. That's very important. If you have it, it's a good thing to have. If you're asymptomatic when you are diagnosed with PML, with natalizumab, your survival is very good, so it's 95%. And therefore, it's important to surveil these people and surveil them with MRIs. The outcome is largely measured by whether or not you can reverse the immune deficit, because our therapies are crappy. These are therapies that in the laboratory work. You could give topotecan, camptothecin, cytosine arabinoside, mirtazapine, chlorpromazine. You know, in the laboratory, you're putting the virus in these cells, cell cultures, you could stop it from spreading. But when you give it to the human being, it doesn't seem to do a whole hell of a lot. Cytoxin shut the viral replication off like that. We did a study many years ago, published in the New England Journal, where we looked at Cytoxin in individuals that were HIV infected. And we looked at it intrathecally, intravenously, or not at all, compared to best AIDS therapy. And as you see here, the Kaplan-Meier curves are superimposable. There's no evidence of benefit, by the way, from plasmapheresis. We all do this, right? You have a natalizumab patient, you go, what's the first thing I want to do? I want to get natalizumab out of their system. You plasmapherese them. But interestingly enough, it doesn't look like that really changes survivability. There may be a reason not to do it. Not that that's the recommendation, but IRIS, as was brought up a bit earlier, is immune reconstitution inflammatory syndrome.
Pretty sure I just read in the last month or so a paper of PML in 2 RA patients who got treated with methotrexate, and no, so I'm sorry, so it had to do with the IRIS. So they didn't develop IRIS, and I'm sorry, confused. I'll come back to it.
Okay.
Sorry.
Not a problem. So this IRIS is you restore the immune system and you get this paradoxical worsening, clinical and radiographic. And you see this, it actually occurs in 2 contexts. And it's not just PML, you see it with cryptococcus or TB or just HIV, or you can see IRIS in the absence of any infection. I mean, people that have rheumatoid arthritis and, you know, you're allowing their immune system to recover. So what it is you can see the emergence of a new disease that you didn't anticipate, or you can see a worsening of a disease that is pre-existing, like you know they have PML. Sometimes you'll stop the drug, or you'll restore the immune system in the AIDS patient, and all of a sudden they develop cryptococcal meningitis as a consequence. Whereas before they were living symbiotically with it. You know, it's like herpes simplex. Have you ever seen herpes simplex in an AIDS patient? No, herpes simplex in somebody who's immunologically normal, bad disease, necrosis, you know. You don't treat that patient with acyclovir right away. They get necrotic temporal lobes. But, you know, curiously, when you're and that's largely because the immune system is causing that problem. If you suppress the immune system, like in the AIDS patient, they can sort of teeter-totter. And, you know, they don't have that same response, and they go for long periods of time. So this is an example of IRIS where there was both clinical and radiographic worsening. This was in a patient with HIV who received antiretroviral therapy. And it's usually CD8 cells, so you get this intense CD8 infiltration, and those CD8 cells are the cytotoxic T lymphocytes for JC virus. The recommendation is to treat them with steroids, but again, this has not been studied. This is just something we make up. And yeah, I was part of making this up. This comes from, I was with a group of Germans who wanted to figure out what to do, and this is what we came up with. But I don't know if it's true. In fact, I wrote a paper on the double-edged sword of steroids for treating PML iris. This is the risk mitigation, and here we go. So if you're negative, your risk of developing the disease with natalizumab is less than 1 in 1,000, probably less than 1 in 10,000. If you're positive,
Sorry,
Yeah,
before
go ahead.
before you go on, have you ever had a case of iris at the same time with PML?
iris and PML, yeah, that's what I'm talking about.
Yeah, but at the same time coincidentally?
Oh, you mean they presented with iris PML? Yes.
Yeah, something like both diseases the same, both.
Yeah, well,
reactions
iris
the
is
same.
just a manifestation of
Yes, I
the
understand.
immune response. So the answer is yes, and where we see it most often is with natalizumab. And I think that the reason why you see so much contrast enhancement in natalizumab PML patients is because they have iris at the time that you've diagnosed the disease.
So basically the iris will get rid of the PML.
Well, we think it does. I'm unfamiliar with any study that says if you have iris, your survival's better, but we think that's the case. I don't know if anybody's looked at that. It's a good thing to look at. This is what Tysabri, or Biogen rather, has published. These are the numbers, 1 to 24 months. If you've had no prior immunosuppressive use, it's 0.6 per thousand. If you have, it's 1 in 500. After 24 months, it's 3 in 1,000 with no prior immunosuppressive use, and it's about 1 in 80 or something like that, if there has been. However, and this is the new European algorithm, I think they just published this in Lancet Neurology or some permutation of it. So these are the numbers. They're not inconsiderable. I don't use the antibody index very much. I don't. Because I don't believe it. And my colleague Eric Williamson, some of you may know him, has been very interested in this and looking at its variability. And it's far more variable than we've been led to believe. So once you're positive, in my opinion. Once you're positive, you're positive. And therefore, at 18 months, I want to get you off the drug. That's what I want to do, if I can. Some people insist on remaining on it. So here's my PML summary. I'm going to end with these last 2 slides. PML is an extremely rare disease due to a ubiquitous polyoma virus called JC virus. It occurs as a stochastic event. It's a completely random chance event. The underlying mechanisms are related to impaired cell-mediated immunity, impaired immunosurveillance, and B-cell activation. They're often the predisposing causes. It results in demyelination from death of productively infected oligodendrocytes, and the most important treatment we have is reversing immunosuppression. And I'll leave you with this because it's one of my favorite quotes. Donald Rumsfeld, as Secretary of Defense, said, "There are known knowns. These are the things we know that we know. There are known unknowns. That is to say, these are the things that we know we don't know. But there are also the unknown unknowns. There are things we don't know we don't know." And I think that's true of a lot of medicine. There are lots of things that we don't know we don't know. Because had you asked me about Tysabri and said, what are we going to see? I would have said, oh, hell, we're going to see toxo, we're going to see crypto, because you're not going to surveil the brain. We're going to see herpes, we're going to see TB, and we're going to see PML. We don't see those things. We see PML, right? That's weird. There are just things we don't know. So keep your eyes open. And the most important thing, particularly for the young people here, always question why. Always question why. And I'll leave it at that and take any questions you have. Thanks. Go ahead.
For the patients with the JC viral meningitis,
Uh-huh.
are they picked up because they have the radiographic findings too, or because they have the other comorbidities?
No, usually there aren't many. I'd be surprised if there are more than 3 in the world's literature, so, you know. But it's the clinical manifestations of a meningitis, not radiographic manifestations, that clue you in. And they're immunosuppressed, and you can't figure out what's causing it, and they have JC virus in their spinal fluid.
So for the JC positive patient, do you tend to use, when you use natalizumab, do you use a modified schedule
No,
every 6 weeks? I mean,
yeah, so John Foley has a study funded by Biogen in which he is looking at every 6 or every 8 weeks.
Right.
And it's more an observational study than anything else, as best I know. And the contention is that if you give natalizumab less often, one of the things we don't do with natalizumab, we give natalizumab in the same dose, regardless if you're a linebacker for the Philadelphia Eagles or you're a 90-pound weakling. It doesn't matter. Yet, does that make sense? And the thought was, well, maybe we're giving too much of it to some people. Maybe we're giving it too often to people. But my belief is that it's unlikely to make any significant difference. If you are suppressing multiple sclerosis, right? Because that's what you're giving natalizumab for. If you're suppressing disease activity, immediately I know that you're not surveilling the brain. Because that's what you're giving the drug for, right? And I also think, although I'm unfamiliar with any study that had looked at this, I suspect that you're releasing the CD34 cells. So my belief is that it's not going to be a positive study. I may be wrong about that, but I don't think so.
Essentially use it for 18 months and then switch to something else.
Well, I'll use it for 5 years or 10 years if they're persistently seronegative and they're comfortable with it.
Positive.
Oh, yeah, if they're seropositive, 18 months I want them off the drug.
And the surveillance scans, I do every 3 months.
Well, then you're more rigorous than most. I think that's great. Do you get like
Not
a
the
full
whole
series?
sequence,
What do
no,
you
I
get?
don't-
Just
I
a flare and
I get the
DWI?
DWI flare, but I don't know whether to add contrast. I wasn't doing contrast
No, I don't
every
think I'd
3
add
months, but I
contrast.
just do it.
Especially with this stuff with the gadolinium being left in your
Correct.
brain
So
forever.
I don't do for the same reason.
Yeah. No, I think that's a great idea. Try convincing most radiologists to do just 2 sequences. They're very unhappy. They'll do it here?
Yeah, I do it here.
No?
I tell them it's just for PML and
Yeah.
I just
What
want
do they charge like 1/4 what they
I
ordinarily
know
do?
about that. But the insurance company also questions me because I'm trying for it too. But they have been, I don't have too many patients, but for my 3 or 4 patients.
Yeah, so I've been doing it I do the serologies every 6 months, or every 3 months in the JC virus negative. And and I do the MRIs as a matter of routine every 6 months, only because it's too cumbersome to try and get it every 3 months.
And for natalizumab associated PML, other than withdrawing the drug, is there anything else?
Well, I put people on mirtazapine and mefloquine, and I've used on rare occasion IL-2 and IL-5, but I don't think any of it does anything. I think, for mirtazapine to work, I think you'd probably have to give them a truckload of mirtazapine to like block all the receptors. It doesn't make a whole lot of sense. Nonetheless, I've had people that have recovered, so I have one patient with sarcoid. It's a crazy story. She was diagnosed with sarcoid. She got 20 milligrams of prednisone for a week and then developed PML. And she had brainstem PML, and it was bad. She was in the ICU for a long time, and I treated her with mirtazapine and mefloquine, and she's now recovered completely. I think that's the weirdest story, because I don't think I can restore her immune system. I can't believe that 20 milligrams of prednisone for a week did a whole hell of a lot. I think she was destined to develop the PML. But, so I'll use it, but I'm unconvinced that it does anything. It's harmless. So.
I'll make one quick comment on your terminology. I've always reserved the term schmutz for the cholesterol plaque at the bifurcation.
Oh, yeah, well.
Different in
It's
specialty, I suppose.
Yeah, it depends what specialty you're in.
Exactly. Same area of the country, probably.
Right. Yeah, it's funny because in Kentucky, nobody understood schmutz.
No, I wouldn't expect. Wisconsin also, they had a hard time.
I have a weird question. So given like there are problems of cancer immunotherapy, would you expect that we'll have a higher incidence of iris in the near future?
So, state that again. In cancer.
Immunotherapy, basically increase the immunity.
Oh, you mean like CAR-T or something like that?
Or like CTO for...
Well, I think yeah, that's an interesting question. I mean, would you see that? Probably not, because the the re-engineered cells are directed to a specific antigen, not to JC virus. We've talked about engineering T lymphocytes to be directed to JC virus antigen. The problem is that JC virus antigen is not expressed on the affected cell surface. So that's a bit of an issue. We've also been toying with the idea with a guy named Jim Wilson, of delivering JC virus antibody, neutralizing antibody. First you have to develop a neutralizing antibody, but delivering it to the brain with an adeno-associated virus, which he's been doing for genetic diseases. I don't know if either would have any effect whatsoever. But we don't think, I mean, most people, and virtually everybody, there's no correlation between antibody levels and recovery. So the humoral immunity doesn't do much. There may be some a rare individual neutralizing antibody that neutralizes the virus, but the only person I know, well, there are two groups, one in Italy, one in Switzerland, that claim that they developed that. But the last time the Italians had published on it was 2014, and I've not seen anything come out of Switzerland lately. So.
Sorry, one more question. So for a patient who is diagnosed with PML, how long you will expect that the radiographic evidence disappeared? And then if the patient develops symptom again, are there any residual like imaging abnormality?
Yeah, there are.
And how do you differentiate the recurrent PML versus just a residual?
Well, I mean, you find the recurrent PML by clinical manifestations and new lesions or enlarging lesions that pre-exist. I have had patients in which the lesions do appear to have improved substantially, and I've had patients who have recovered from PML and actually wrote one up. I had a patient, I don't mind using his name, I often have a picture of him, a fellow by the name of Ron Wiebeck. It's a great story. I had these patients in, this guy, Ron Wiebeck, was a waiter on Cape Cod. And he started thanking his left hand for helping him clear the table. You know, he'd be clearing the table and go, "Oh, thank you." He'd go, "Wait a minute, that's my hand." And he had an alien hand syndrome. And he went and he went to a place called the Massachusetts General Hospital. And he was cared for by a guy named Len Mookie. Some of you may know Len if you're in the dementia world. He was a resident there at the time. And they proved that he was HIV infected, and he had a lesion in his brain that was hypointensive. It was before MRIs. Had a hypodense lesion with contrast enhancement around it, and of course, back then we thought 99% of the time it's toxo, so they treat him for toxo. He doesn't get any better. It's getting worse. So much worse that he's severely hemiparetic and hemisensory loss. He gets a field cut. He gets biopsied. Who reads the biopsy? E.P. Richardson Jr. E.P. Richardson Jr. is the guy who described PML. He says, this is PML. They find the common T antigen, it's PML. He's on one drug. We had no antiretrovirals. He's on one drug. He's on a drug called Dilantin. Why is he on Dilantin? Because the surgeon who biopsied him said, well, maybe he'll have seizures, we better put him on Dilantin. His family lives in Central Florida, and he goes home to die. His CD4 count, by the way, was like 700, so it was high. And it wasn't because he was co-infected with HTLV1. We had no explanation for why his CD4 count had to be so high. And he came down to see me because I was the local authority. And the first time I see him, he's pretty ill. Second time he's better. The next time he's better still, and he's better still. I'm not doing a damn thing for him. I left him on his Dilantin. And eventually, all he was left with was a little disability in tapping his foot. And he said, this is like a year and a half out, something like that. It's in the paper. He said, can I go back to work? And I said, sure, go back to work. So he goes back to work and he's doing great, not being treated with anything. Then I had a few more of these patients and I said, wow, this is the weirdest damn thing. How is this happening? So I called up Gene Major. Some of you may know Gene. He was at the NIH, still is, but retired. And he's like a virologist that does PML work. And I said, Gene, would you and Sid Huff was working with him, a neurologist. Sid ultimately became the chair at Loyola and then joined my faculty in Kentucky. And I said, would you guys take these patients and figure out what the hell's going on? They said, yeah, this is fascinating. So this is in the era before PCRs. You have to culture the virus. So they take Ron, among other patients up there, and they look at his spinal fluid. They don't re-biopsy him. They look at his bone marrow, they look at his blood, and they tell him they can't find the virus. They couldn't find the virus. Now, had they done PCR, I think they would have found the virus, but culturing it, they didn't find the virus in the spinal fluid. What does he hear? I'm HIV free. They didn't tell him it was JC virus, or he didn't understand that. So he thinks he survives HIV. And he is now in Parade magazine, East West magazine, a bunch of AIDS publications, as somebody who's recovered from HIV in the absence of any treatment. So I get a phone call. Ron had given me permission to chat. From some San Francisco gay publication, they said, we understand that Ron is free of HIV. I said, well, that's not true. No, he still has HIV. He's free of, we can't find JC virus, the cause of PML. And he reads this, that I say he still has HIV. And I get a call a month later. Now picture this, every Christmas I would get these wonderful Christmas gifts from Ron. I mean, just fantastic. I still have one on my desk. It's the straw man, the scarecrow from Wizard of Oz, and it has, if I only had a brain, on the bottom of it. I have it on my desk. And Ron says, I'm very angry with you. I said, why? He says, I'm in the hospital. I read in the newspaper I still have HIV. I thought I was free of it. Once I read that I still had HIV, I got severely ill. I said, what are you in the hospital for? And he was in the hospital, not with PML, but with tuberculous pericarditis, which was treated and he did fine. And then 6 or 8 months later, he developed lymphoma and he died, not PML, lymphoma. And the PML never recurred, and he died. I never got any more Christmas gifts from him. But talk about psychoneuroimmunology, I don't know if you guys believe in this, but here, he's doing great, Oh shit, I still have HIV, and boom, he was sick and in the hospital. Weird, isn't it? It's weird. Anyhow, I forgot how I got onto that. But that's my Ron Liebeck story. All right. Thank you very much.
Thank you.
Sure.
Great. And thank you again for coming.